talk about carcinoma of larynx. So in ENT, most common cancer is SCC, squamous cell carcinoma, most common. Okay, now what are the predisposing factor? So cancer, so most risk factor or predisposing factors are smoking and HPV virus. Patient comes with hoarseness of voice. Okay, now there are just types of laryngeal cancer, larynx cancer. So how many types? There are 3 types. Okay, the most common is glottis, most common and best prognosis. Then supraglottis and subglottis. Okay, this is the most common. Now next, what is the earliest presentation in this? So patient comes with hoarseness of voice. This is the earliest presentation. Okay, in case of supraglottic, there is dysphagia. Let's write it down here. Dysphagia and a lymph node enlarged. Subglottic, we have stridor. Stridor means high pitch wheezing sound. Sound like that. Okay, in subglottic. And in all of these cases, patient come with pain in ear, referred pain in ear. This pain is referred by vagus nerve, also known as Arnold's nerve. This pain is by Arnold's nerve. Okay, next is, what is the clinical scenario? Then question will be like this: a 50-year-old male patient who has chronic smoker presents with hoarseness of voice for more than 3 weeks. What is the next step? So obviously laryngeal endoscopy will be done. So in these cases, I have a 40 to 70-year-old patient with hoarseness of voice, pain in ear. Mostly this is the most common, and this also can happen, whatever. Next is, what is my next step? So investigations. So I will do laryngoscopy, laryngeal endoscopy. I have multiple options, like the most important is laryngeal endoscopy. It will show me a ulceroproliferative mass. But I am giving an exam, so I have multiple other options as well. So exam, I have to write about indirect laryngoscopy, direct laryngoscopy, micro laryngoscopy. All these are present, whatever. Now main point is these are just for prof exam. After this laryngoscopy, what we'll do, I'll do for confirmation I will do biopsy with anesthesia. What I will use in anesthesia, I will anesthetize internal laryngeal nerve, I will anesthetize internal laryngeal nerve. Then after that I will do neck examination for lymph nodes. After this I also have CT and MRI for bone and cartilage. Neck examination. Okay. Then I will do all of that. After all of that I will do TNM staging. Now just write about the TNM staging, what I have to do. T1 means only one site involved. Vocal cords are mobile. Okay. For T1, let's first talk about the T1, T2, everything. Next comes so what I will be my treatment in T1. It will be radiotherapy, or TLM by carbon dioxide laser. What is TLM? It is transoral laser microsurgery. Okay, this is in T1. If it is not available, then we can do vocal cord stripping. And then next is T2. T2 means adjacent sites are involved. Here I have a good thing. If T2N0 is the cancer, then I have two scenarios. First one is vocal cords are mobile. Then I will do radiotherapy. If failed, If failed, then I will do conservation laryngectomy. If it is also failed, total laryngectomy with neck dissection. Or I can directly do this as well, directly from this to this. If I have vocal cord mobility immobile, or anterior commissure of arytenoid involved. T2 means the subsided things will get compromised. So in that, if this happens, the adjacent arytenoid is involved, then I will do this part. No radiotherapy, direct conservation laryngectomy. I know I can write like this, but in here it is written like this in book, so just follow the book. If failed, then total laryngectomy with neck dissection. Now T4. What about T3? T3 means fixed vocal cord. Fixed vocal cords. So treatment is concurrent radiochemotherapy. Concurrent chemo radiotherapy. What chemotherapeutic agents are used here? Cisplatin, 5-fluorouracil, etc. Okay. Next is T4. T4 means local invasion or unresectable. Many things are there. T4A means local invasion. So I can just cut it out. If I can cut it out, then name it like that. Total laryngectomy with radiotherapy. T4B means unresectable. That means I cannot cut it out. So what I will do, I will do palliative care. Just palliative care, ভালোবাসা দিয়ে ছেড়ে দেবো। This is things. After all of this, we have to also understand there is neck involvement. So let's see this question. A patient presented with hoarseness of voice and difficulty in swallowing. On examination, tumor biopsy revealed squamous cell carcinoma involving supraglottis and glottis with bilateral mobile vocal cords. Mobile vocal cords. Okay. What is the management of this patient? Bilateral mobile vocal cords means it is either T1 or T2 staging, not involving any other thing apart from the main points, that is subglottis or glottis. So T1 T2 means radiotherapy or TLM, simple, transoral laser microsurgery. Mostly answer is radiotherapy in our case, until unless he is very bad and T4. So here just write a cheat code for these questions. Cheat code is, if bilateral vocal cord mobile, then I will do radiotherapy or transoral laser microsurgery. If vocal cords are impaired, this is not immobile, this is impaired, then I will do radiotherapy. Even though if vocal cords are fixed, only then I will do chemotherapy, concurrent chemo radiotherapy, chemo radiotherapy. If question said tumor is spread to pre-epiglottic space or paraglottic space or post-cricoid space, I will do the same thing. If tumor spreads আশেপাশে, I'll do the same thing. But if it says that if tumor spread to thyroid, that means out of larynx, then I have to do total laryngectomy with radiotherapy, because it is out of the larynx, right? So it is too much going out of hand, that's why. Next, as per management of lymph nodes, these are tumors. For lymph node, I will do either radiotherapy or surgery. I will do either modified radical neck dissection, modified radical neck dissection, where what I'll do, so modified radical neck dissection করব, অথবা আমি আরেকটা করতে পারি কি, রেডিওথেরাপি করতে পারি, সিম্পল রেডিওথেরাপি। মডিফাইড র্যাডিক্যাল নেক ডাইসেকশন মানে কি? প্রথম কোশ্চেন আসবে মডিফাইড কেন, what does the modified means and what we do in this case. In modified radical neck dissection, I remove lymph node 1, 2, 3, 4, and 5 is removed, right? All these are cut out. Why it is modified? Because it preserves many things. I will remember spinal accessory nerve, spinal accessory and internal jugular vein, spinal accessory, spinal nerve, that won't happen, accessory nerve, spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle. These are preserved. In selective neck dissection, N0 supraglottic carcinoma is done. In not supraglottic carcinoma done. Lateral neck dissection, lymph nodes 2, 3, and 4 are removed due to high possibility of occult metastasis. If after all this treatment there is one thing, that is rehab, so I have to rehab the patient as well. For rehabilitation, he won't be able to speak. So to make him speak, we will help him with esophageal speech, tracheoesophageal speech, tracheoesophageal speech, electrolarynx, etc. And if after all of this, if recurrence happens, then obviously this time I will cut it out, laryngectomy, but I won't cut it out all the way, so open partial laryngectomy will occur. Patient with a tracheostome, these patients won't be able to cough and lift heavy weight. So this is the entirety of carcinoma of larynx.